Welcome to this medicine masterclass on genetic liver disease. We will talk about autoimmune hepatitis, hereditary haemochromatosis, alpha-1 antitrypsin deficiency, primary biliary cirrhosis and primary sclerosing cholangitis, and Wilson's disease. Let's start by talking about autoimmune hepatitis. This is an inflammatory liver disease characterized by autoantibodies directed against hepatocyte surface antigens, resulting in acute hepatitis. Patients would present with signs and symptoms suggestive of chronic liver disease and constitutional features of autoimmune conditions. They may have jaundice, pruritus, fever, malaise, rashes, polyarthritis, pleurisy, pulmonary infiltration, and glomerulonephritis. There are three key types of autoimmune hepatitis: type 1, 2, and 3. Type 1 is the presence of anti-smooth muscle antibodies and usually affects adults or children in a bimodal distribution and responds well to low-dose steroids. And this is a classic form of autoimmune hepatitis. Type 2 autoimmune hepatitis has the presence of anti-LKM or anti-liver kidney muscle antibodies, and this usually affects young women or girls. And this has rather severe disease and progresses on to cirrhosis rather quickly. Type 3 autoimmune hepatitis is the presence of antibodies against soluble liver antigen or soluble liver pancreas antigen, and rather similar to type 1 has a bimodal distribution and responds well to low-dose steroids. A fourth type is autoimmune hepatitis in the absence of autoantibodies. The management, of course, depends on determining which type of autoimmune hepatitis the patient has and treating them with steroids or other immunosuppressants such as azathioprine. And if the patient develops decompensated disease, they may require liver transplantation if they become refractory to medical treatment. In some cases, a cholecystectomy may also be advocated in the presence of gallbladder polyps. Hereditary haemochromatosis. This is an autosomal recessive condition affecting the HFE gene on chromosome 6. This is a disorder of iron metabolism, which leads to increased intestinal absorption of iron, which then deposits in multiple organs. So the patient may be asymptomatic as it has an insidious onset, but then eventually will develop tiredness, lethargy, arthralgia, and impotence. The patient may appear bronzed or have a grey appearance, and this is the iron depositing in the skin. They may develop bronze diabetes. This is the iron depositing in the pancreas, causing dysfunction of insulin. They may have signs of chronic liver disease as the iron deposits in the liver. They may develop hepatomegaly, erythema, spider nevi. Iron can deposit in the pituitary and the gonadal tissue, resulting in loss of secondary sexual characteristics as well as testicular atrophy. In order to investigate these patients, serum ferritin, iron should be sent, and these would be elevated. The total iron binding capacity would be naturally reduced as the excessive iron is binding to proteins, and the transferrin saturation would be very high. In the joints, on x-rays, you may see chondrocalcinosis, and the liver ultrasound duplex and MRI as well as liver biopsy would show the deposition of iron in the tissue. Pearl stain quantifies iron loading, and the patient would require HFE genotyping to determine the abnormality in the gene. To manage these patients, they should be asked to avoid alcohol, avoid foods prepared in cast iron cookware, and they may require regular venesection to prevent cirrhosis and hepatocellular cancer, and this can be as regularly as weekly. If the patient hemodynamic state does not permit venesection, then they may require an iron chelating agent such as desferrioxamine. Family members should be screened for early detection. Let's talk about alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a serine protease inhibitor, and so deficiencies of alpha-1 antitrypsin is also known as part of the serenopathy group of diseases. Alpha-1 antitrypsin controls inflammatory cascades. It's synthesized in the liver, and if you have a deficiency of alpha-1 antitrypsin in children, that will go on to cause liver disease and in adults can cause liver disease as well as lung disease. In the lungs, alpha-1 antitrypsin protects against tissue damage from neutrophil elastase. The condition is autosomal recessive, and the gene for alpha-1 antitrypsin is found on chromosome 14. The genetic variants are classified by the electrophoretic findings, and patients can either be medium, slow, or very slow, denoted M, S, or Z. The slow and very slow subtypes occur due to substitutions at position 264 and 342 and result in decreased production of alpha-1 antitrypsin deficiency. The normal variant are the medium, PIMM. PIZZ are the highest risk of aggressive disease, whereas PIMZ and PISZ are slower risk of developing liver disease. The symptoms, so if you have the aggressive genotype, the PIZZ, then you develop dyspnea from emphysema and complications of liver disease, including cirrhosis and cholestasis. As a result, the patient may have multi-system involvement. To manage these patients, supportive treatment to help manage the emphysema and cirrhosis is instituted, and patients can be supplemented with alpha-1 antitrypsin pooled from human plasma, particularly if the FEV1 is less than 80%, the patient is a non-smoker, and a patient-centered multidisciplinary team approach has been made. If the patient advances to advanced liver disease, they may be considered for liver transplantation. Let's now discuss primary biliary cirrhosis and primary sclerosing cholangitis and the key differences. Note that PBC predominantly affects middle-aged females, whereas PSC affects younger patients and males. Primary biliary cirrhosis results in granulomas, and primary sclerosing cholangitis results in concentric onion ring fibrosis and strictures. Primary biliary cirrhosis patients are usually AMA positive, and primary sclerosing cholangitis are usually ANA and ANCA positive. Primary biliary cirrhosis is associated with Sjögren's, and primary sclerosing cholangitis is usually associated with ulcerative colitis. So clinically, primary biliary cirrhosis, females more than males, middle age, they present with fatigue and pruritus. They would have a cholestatic picture, and there is intrahepatic damage resulting in granulomatous inflammation of the bile ducts, and they would be AMA positive, associated with rheumatological conditions such as Sjögren's. And the complications of primary biliary cirrhosis include cirrhosis of the liver, osteoporosis, coagulopathy, and an increased risk of hepatocellular cancer. Primary sclerosing cholangitis, in which males are affected more than females, results also in a cholestatic picture, but as well as intrahepatic, there's also extrahepatic damage resulting in fibrosis of the bile ducts. And there's a concentric onion ring fibrosis around the bile ducts, giving rise to a beaded appearance. They're usually AMA negative, and in primary sclerosing cholangitis are ANCA or ANA positive, and is usually associated with other gastrointestinal conditions such as ulcerative colitis. But patients can go on to develop cirrhosis as well as colorectal cancer and cholangiocarcinoma. To manage patients with this autoimmune condition of PBC or PSC, medically, pruritus as a result of the cholestasis can be treated with cholestyramine or ursodeoxycholic acid, and antibiotics if the patients develop cholangitis. Interventionally or radiologically, endoscopic stenting can help with biliary strictures, and they would require regular imaging of the biliary tree. Surgically, if there are no medically curative options, the patient may be considered for a liver transplant and a cholecystectomy if the patient develops gallbladder polyps. Wilson's disease is another important autosomal recessive condition that can lead to liver failure. This is caused by a mutation in the copper transporting protein ATP7B. The defective gene is located on chromosome 13. Copper accumulates due to failure of biliary copper excretion, and that if it accumulates in the brain tissue, that's known as hepatolenticular degeneration. The patients would have symptoms of liver disease, including hepatitis, cirrhosis, and fulminant liver failure. In the brain, they could develop complications, including psychiatric problems, tremor, dysarthria, dysphagia, dyskinesis and dystonia, as well as earlier onset dementia and Parkinsonism. Psychiatric complications include depression, mania, labile emotions, and memory impairment. Wilson's disease is scored according to the Leipzig scoring system. If patients have the presence of Kaiser-Fleischer-Ring's neurological symptoms, which can be graded as severe, mild, or absent, the serum keraplasmin, the Coombs negative hemolytic anemia test, liver copper levels, as well as urinary copper levels and mutation analyses are all scored together, and a score of 4 or more indicates that the diagnosis has been established. 3, an intermediate possibility of diagnosis with the requirement of more tests, and a score of 2 or less indicates that the diagnosis is unlikely. And you can see here Kaiser-Fleischer-Ring's, a green-yellow discoloration at the periphery of the cornea, readily seen on slit lamp, suggestive of Wilson's disease. So to monitor and manage this patient, supportive treatment, so dietary, avoid high copper content foods such as liver, chocolate, nuts, mushrooms, legumes and shellfish. Medically, chelating agents such as penicillamine are helpful, and if the patient develops advanced liver cirrhosis, this should be considered for liver transplantation. Thank you for attending this medicine masterclass.